Good afternoon. My name is Jessica. This is Module 1 discussion for Nursing 482. This discussion will mainly be on pharmacokinetics. I'm going to draw off my clinical experience in neurocritical care. So let's first talk about pharmacokinetics. Pharmacokinetics is the study of a drug's movement throughout the body. So it goes through 4 cycles: absorption, distribution, metabolism, and excretion, all of which are very important for us as nurses to take note of. So absorption. Depending if the drug is IV or PO, it affects the absorption. Might skip right on down to distribution. So absorption, we think taking in. Distribution, the way it's distributed. So blood to tissue. Some drugs may have to stay a free molecule, unbound, until they can move in tissue. So we might need proteins to aid in that process. Also, if a drug's crossing the blood-brain barrier, might need to be lipid soluble. Metabolism. A lot of times we think of the liver, because the liver is a major organ that affects metabolism. So if a person has liver failure or a toxic liver, certain drugs might not be the best choice. Excretion. Way the body gets rid of it. So kidneys are one major organ that we relate to for excretion. So if the person's in renal failure, drugs might not be appropriate if the kidneys aren't working appropriately. Might need a smaller dose because the body holds on to the drug, have increased levels in their system, might not be able to get rid of it. So I'm going to talk about an incident. Patient had a right MCA occlusion with minor intraparenchymal hemorrhages and elevated in ICP. So a major drug that we give on our unit for elevated ICP is mannitol. Mannitol is an osmotic diuretic. It is great for ICP, to lower ICP. Also are used in intraocular pressure or if the person's in oliguric phase of renal failure. Usually the drug is dosed based on 2 grams per kilogram. There's available concentrations ranging from 10 to 20%. Usually it's drawn up in a vial. To give mannitol, it crystallizes very quickly, so you have to monitor the medication for crystals before administering, because then it would be very extremely harmful on the vessels. Mannitol also has to be pushed to a filter. Okay, back to pharmacokinetics. So, usually it's administered in a bolus, IV, usually in a central line. It expands the circulating volume. It's going to decrease the blood viscosity, and therefore it's going to increase cerebral blood flow. And, in return, going to cause cerebral oxygen delivery. So, a thing that happens, it will decrease the extracellular fluid. It's pulling the fluid off. That's what we want. So, mannitol affects the tight junctions of the blood-brain barrier. It's usually open for 30 minutes. Mannitol itself directly affects the breakdown of blood-brain barrier, so it has to be used wisely. Usually mannitol is administered in emergent situations or possible herniation. In my situation, the patient had fixed, dilated pupils, no neurologic response. Mannitol was inevitable. Based off CT scan, it showed increased cerebral edema. Mannitol is given to decrease the amount of edema, swelling, and fluid in the skull, on the brain. So, precaution, it can cause hypertension. Why? Because it's pulling a lot of fluid off. Where is it excreted from? The kidneys. Usually it appears in the kidneys within 3 hours. It raises the osmolarity of the GFR. So, it's going to decrease the reabsorption of the tubular of the kidney. This will heavily affect sodium and chloride. So to maintain homeostasis when giving mannitol, if a person is not hydrated, we will usually give boluses with mannitol, bolus of fluids, or put them on a drip to maintain the blood pressure, such as Levophed or Neo. So, with a precaution with mannitol, we check for osmolarity. If it's greater than 320 osmoles, we won't give it. Why? It can cause ATN, acute tubular necrosis. So mannitol, an osmolarity level is drawn an hour prior to administering mannitol. Osmolarity, for those, it's a concentration of osmotic solution. So, pharmacogenetics, I couldn't find much research on this on mannitol. I'm sure there's genetic differences in metabolic pathways that would affect the absorption and excretion of mannitol, but I would be interested in finding more on this topic. I did not find any academic reviewed resources. The resources I used for this discussion was the Merriam-Webster Dictionary, the RX list on mannitol IV drug, trauma.org, and also I used our Nursing 482 Pathophysiological and Pharmacological Evidence-Based Care from the University of North Carolina, Wilmington. Thank you.